So let's see. Again, supportive. We're always trying to do everything we can to, as I just said, maintain oxygenation while we wait for the lungs to heal. There's really nothing we can do for ARDS except maintain our patient and then wait for the lungs to get better. And they also have a note down here that remember ARDS is always precipitated by some kind of event that leads into it. So anytime your patient has trauma, your patient is septic, your patient has pneumonia, smoke inhalation, any of the things that are the big precursors to ARDS, you should start watching for signs of ARDS as soon as they come into your ICU. Because as soon as it appears that they're going into ARDS, we want to immediately be in this lung protective mode now. High FiO2s, high PEEPs, low tidal volumes, high rates. And then we'll talk later on in the term, if that doesn't work, we move to some more non-conventional modes of ventilation to help with oxygenation. Make sense? Okay. Last but not least, the trauma patient. We focused here specifically on the head trauma patient. Number one, if they have severe brain damage, they're not going to be able to breathe on their own at all. Otherwise, the problem is going to be the increased pressures and the high ICPs that we have from the trauma. Oh yeah, it's right. So this patient needs to start in ACVC. We had a conversation about starting this patient in ACPC because of their high ICPs, and I understand that rationale, except in the beginning, when our patients first come into the ICU, they're going to have severe trauma, and within the first 24 hours, is that going to get worse or better?
Worse.
It's going to get worse, so that's going to make your ICP even higher. So what we do in this patient is we do what's called controlled hyperventilation, which leads to hypocapnia, which is why I say be very careful, because in the trauma patient, we want to overventilate them on purpose. Hyperventilation. So the idea here is your patient comes in. This is only a temporary measure, which we'll talk about in a minute. We put them on 100% FiO2, the same tidal volume ranges, the 6 to 8, but we're going to hyperventilate them, and I just put the starting range of 18 to 20. The idea is to drive down the CO2. And this is not up here, so write this down. Your goal of your CO2 for your patient in the first 24 hours is 25 to 30. If I bring my CO2 down, it causes vasoconstriction. If I vasoconstrict, I decrease blood flow to the brain. If I decrease blood flow to the brain, I help drop the pressures. Yes, decreased CO2 causes vasoconstriction. Vasoconstriction happens, you'll have less blood going to the brain. Less blood to the brain, lower ICPs. This is only a temporary thing for two reasons. Number one, if I'm blowing off my CO2, it's going to make my pH high. What's going to happen over time, in a very short amount of time? From an acid-base perspective, ABGs. They're going to be alkalotic, so what's going to happen what's the body going to try to do? Compensate. So it's going to kick in with bicarb, or no, drop the bicarb to try to bring the pH down. So it's only temporary, because if you do it for longer than 24 hours, your body's going to try to compensate anyways. The other reason is, it's controversial for another reason, but I'm going to explain this and then we'll take our break. You've got a trauma patient who's had severe head injuries. Now keep in mind, when you guys are doing your SIMs and things like this, or you're seeing your patients in the emergency room, it's not always going to be put out in black and white. Your patient's ICP is high. What do you want to do? Your ICP is 30. What do you want to do? They're going to tell you they had severe head injury, head trauma from an MVA. You should figure out from that they have high ICPs. So they come in, if they have massive brain trauma, what's gonna happen if we reduce blood flow to the brain? What else are we gonna reduce? Oxygen getting to the brain. So that's why it's controversial. They say, well, we don't want to reduce oxygen. Well, at the same time, we know if our ICPs are too high, your patient's going to have a brainstem infarction and die anyways. So this is really only meant to be used. Your patient comes in the ER, massive trauma, massive inflammation. You've got to get them to surgery to try to relieve some of that pressure, or they're going to do the drill and put the hole in and to relieve some of the pressure. This is meant as a temporary measure when you're in that stage where anything and everything needs to be done to try to get the ICPs down. And once that's managed, then we're going to go back to a regular rate because we want to promote oxygen to the brain as much as we can. So, but otherwise, monitor your patient's ICPs and do everything you can to not stimulate your patient. We've talked about that before. Keep the room quiet, don't suction. Keep the patient as still as you can, paralyze them, things like that. The least amount of stimulation as possible to do everything we can to keep the ICPs down. So overventilate. So if you put your patient on the vent, this is a common boards question, you put them on the vent and you get an ABG. Head trauma in the emergency room, ABG comes back, it's 7.45 and the CO2 is 38. And it asks you, what do you want to do? And you all go, maintain current settings because my ABG looks good. However, you're not picking up on the fact that it's a head patient and you need to lower the CO2. So the correct answer in that situation is to go up on the rate. But now you have the opposite problem. You put your patient on the vent, they're head trauma, you come in, your pH is 750, your CO2 is 30. What do you want to do? Oh, I want to bring down the rate. No, you don't. You want to maintain current settings. Those questions always come up on the boards. Those are gimmies. Pay attention to what they're telling you and answer appropriately. Make sense? All right, I'll leave this on the board. Take your break.
It's freezing all of a sudden.
I know, it's not cold in here all
Now
the
I'm cold. I wasn't when you said that.
Oh, yeah, touch it.